Good afternoon, everybody. Welcome to this meeting, this CME meeting that is organized by the UROD. UROD is an initiative of the CKD-MBD working group. And as you can see in this slide, is a very active initiative that is trying to lead and study renal osteodystrophy. And to do this, there is the aim to realize a number of initiatives aiming at revitalizing bone biopsy, promote research in ROD by a huge and large database and virtual biobank of bone biopsy, and try to collaborate with other societies in the world. Another initiative of this UROD is, as you can see, to organize conferences. And one of these conferences, next slide, are all realized in Leuven. And here you can see the date of the next winter meeting. I encourage all the attendees to join the CKD-MBD working group and to participate at this Europe winter meeting. So, having said this, here you can see just a couple of examples of studies that have been published at this very active group on points and on subjects that are very important and critical for those researchers that are interested in CKD-MBD. And now I think that we can move on. And I think that I need to underline to the participants that there is the possibility of having a real-time translation because this is obtained through an audio and caption translation by a system of AI, artificial intelligence. There are 7 different languages that every body can select by going and clicking on the globe icon and selecting the language they prefer. Captions can be translated by an external link that is available. So, having said this, I'm very glad to introduce quickly Carina Ferreira, which is from Portugal. She will present the case of today to be discussed. She works in Portugal and very interested in bone biopsy. There are 2 panelists, Ditte Hansen and Ricardo Neto. Ditte is from Denmark. She's a nephrologist and very interested. I think that we need to have a special dedication to this argument of CKD-MBD to participate. And the same can be said for Ricardo Neto, who is similarly from Carina Ferreira from Portugal. So I think that I can stop speaking and give place to Carina.
Thank you. Thank you for having me. I'm going to present a clinical case about a patient with muscle weakness and hypophosphatemia. And before I start, I would like to thank to a colleague of mine, Miguel Ferreira, who is currently following this patient. So these are my conflicts of interest, which are not related to this presentation, and about the clinical case. So we have a middle-aged woman, Caucasian and autonomous, with a medical history of hypertension and dyslipidemia, which is medicated with perindopril and simvastatin. She was okay until 2022, when she started with symptoms of bone pain, muscle weakness, incapacity to walk without help, and she ended up in a wheelchair. She had also inability to get out of the bed without help, and she had a pelvic fracture in January 22. So she went to her physician. He asked for some lab results, and then she was referred to the nephrology department. I'm sorry, Sandro, you are muted.
Okay, can I ask you if the fracture was secondary to a fall, or was not secondary to a fall? Because
Was secondary to a fall, yeah.
Okay.
Because she had muscle weakness, and she couldn't walk without help, and she fell. Yeah, she fell.
So this was an accident. I think it could be helpful to remember to the participant that falling and having a fracture is not normal. If you fall when standing or when walking, you are supposed to face the trauma without having any fracture. So I think this can be regarded as a pathologic fracture.
Thank you.
I don't know if you want to make any comment on this.
No, she had the fracture. She was seen by a physician, and she was in rest for helping in the pain, and she didn't need to do any surgery or anything else besides being in rest. Although because of this, she perform a bone densitometry, which I'm going to present you later on this case.
Can I make a comment?
Oh, yes, please.
Okay, so at this time we have a postmenopausal 63-year-old Caucasian woman, which had a pelvic fracture 2 years ago, from which she apparently recovered. So it's clear that she has got some risk factors for osteoporosis. Carina has told us that she performed a DEXA scan. She'll present, I suppose, later on its results. And after recovering, she came to develop a rapidly debilitating condition consisting of bone pain, muscle weakness, and at this point, before getting and seeing the results of our biochemistry workup, it's still difficult to say what's going on. But of course, we could now be facing an osteoporosis, but also any kind of autoimmune disease like fibromyalgia, polymyositis, dermatomyositis, but it's still a bit early to make a differential diagnosis. So indeed, we need some more information.
Thank you. Indeed. So when she was referred, she came with some blood results, and we could see that she had normal kidney function, and she had a hypophosphatemia with normal calcium, normal magnesium, a normal uric acid, and a urine analysis that was also normal. So the kidney ultrasound revealed no abnormalities, and we asked for further blood analysis.
Okay, I don't know if anybody of the panelists want to make some comment on this.
So we know that the patient has a moderate hypophosphatemia. We know that the serum calcium is normal. We miss here the IPTH, which by now is essential, and there is a significant. And besides that, we know that the patient has no evidence of CKD, so supposedly this will not be a case of renal osteodystrophy. That we probably can say for sure. But next step would be to know what her PTH might be.
Yeah,
I would also suggest to consider the hypophosphatemia that also may be present. So perhaps consider paraproteinemia, measuring the ITM components and see if there should be any other causes of the hypophosphatemia than a real hypophosphatemia.
yeah, absolutely. Yeah, for sure. I don't have that results, but I can say that the PTH was slightly elevated. The vitamin D was more or less normal. And we had a very high alkaline phosphatase level, a very low 125 vitamin D, and bicarbonate was also normal.
Okay, I think it's necessary that one of the panelists makes some comments about these derangements. Now the clinical picture is a little bit clearer.
Yeah, you're right.
Yeah.
So we know now that PTH is more or less normal in the upper limit of the normal range. This might by now rule out an hyperparathyroidism, other conditions like vitamin D intoxication and sarcoidosis. But in the face of hypophosphatemia with normal calcium and near normal PTH, perhaps next step now would be to check the fractional excretion of phosphate in urine. It's noticeable that the 125 vitamin D is undetectable, and there is a considerable rise in alkaline phosphatase, which is relevant. Yeah.
Okay, there are some questions from the audience, and the first one is to give more details on the bone pain. This is by Peter Evenepoel. What kind of pain? Which bone? Continuous day and night pain worse with exercise. So can we have details on this?
Yes, she had continuous bone pain, and it was more in the lower limbs, but also in arms. And she did not drink alcohol. That I'm seeing this question also.
Yeah.
And she didn't receive any IV iron to justify the low phosphate also.
Okay.
She didn't had I think she didn't had arthralgia. Yeah, she only had bone pain and muscle weakness, so she couldn't stand up, and she progressively lose the capacity to walk alone.
Okay, and now you maybe that you've seen that there is a question about urinary phosphate and calcium.
Okay, I'm going to show you in the next slides. Yes. So by this time we can review the homeostasis of phosphate, and we know that phosphate is one of the most abundant minerals in our organism, and the main source is the diet. So when phosphate is absorbed, it can either go to the to the cells, or can be deposited in bone, or can be excreted by the kidney. And a very small fraction is also excreted in stools. We know that 85% of phosphate is deposited in the bone, 15% is in the soft tissues, and only 1% is in the extracellular space. Phosphate is also balanced by three main hormones, which are the PDH, vitamin D, and FGF23. So if we think about the previous slide, we can think that hypophosphatemia either is about a movement of phosphate into cells, or there is a decrease in the intestine absorption, or there is an increase in the urinary excretion. And because of that, we perform a fractional excretion of phosphate, as Ricardo asked us and suggested to do. So we talked with the patient. There were no relevant family history for this finding, and the fractional excretion of phosphate was elevated. And we could conclude that the cause of hypophosphatemia was an increase in the urinary excretion of phosphate.
Okay. I think that at this point, there may be other questions. For example, we didn't underline that this patient had a normal bicarbonate level. So we can exclude that there was some kind of acidosis in the clinical picture of Fanconi, any of the Fanconi syndrome. But nonetheless, we could try to have some data on Benz-Jones proteinuria or free light change or some paraproteinemia.
Yeah, the patient had no excretion of proteins, and she had no aminoaciduria in the urine. So the RAC, the urinary albumin creatinine ratio and the urinary protein creatinine ratio were completely normal. She has a normal plasma electrophoresis, and I think that the immunofixation was not requested.
Okay, a question from the audience is the fractional excretion was obtained on a fasting urine sample or on a 24-hour collection?
No, it was in a fasting urine sample.
Okay, I think that we can underline that this is the correct way to make evaluation of fractional excretion, because there may be diurnal variation in the value. So the reference is with fasting sampling.
Yes, and this was the how we calculated.
Okay, we can also remember to the audience what is the accepted normal or higher value of fractional excretion of phosphate in normal subjects.
Yes, above 20 is a high fractional excretion, but in case of hypophosphatemia, usually the kidney try to, if the kidney is not the source of the reason for that, the kidney will try to not excrete as this quantity.
Okay.
So we can think about Fanconi or its causative drugs, and we excluded. Also, the very low vitamin D level was also excluded. The hyperparathyroidism was excluded, but we also can think about the phosphatenins. There are the cause for rickets or for tumor-induced osteomalacia. And for this reason, we ask for FGF23 determination, and it was high, it was elevated. And we also ask for the genetic test, although we, by the history, we exclude the hypothesis of an X-linked racketism or rickets or other causes, genetic causes of rickets, but we ask for the genetic test, and we didn't find any abnormality.
Did you explore the family history?
yeah, we asked for the family history, and there was nothing relevant for the hypophosphatemia in her family.
Well, I think that we should also underline that the development of the clinical picture occurred in a rather rapid time. It dated back only 1 or 2 years. So
Yes.
I don't know if you checked the length of duration of muscle and bone pain in this patient, because it seems something that developed rather quickly, because hypophosphatemia needs to last a long time in order to be responsible of rickets. It's not something that happens in 1 week or 2.
Yeah, of course. Well, the patient was okay, and she went to her physician only when she had a long period of bone pain and muscle weakness. She didn't went to the doctor very quickly. So I think that it was 2-3 months of pain. Then she did perform the blood tests, and then she was referred to us maybe 6 months after the initial development of the clinical case.
Carina, let me make 1 or 2 comments. I'd like to highlight the real value of measuring the FGF23, because since we know that the fractional excretion of phosphate is increased, this is clearly a case of renal phosphate wasting, and so measuring FGF23 tells us whether this wasting is or not mediated by FGF23. So since it is not normal, a Fanconi syndrome seems very unlikely. In fact, you told us in the beginning that the serum bicarbonate was normal, acid uric was normal, there was no proteinuria, so probably no aminoaciduria, no family history, so this seems to be coherent in terms of excluding a Fanconi syndrome. Since it is increased, it could be a genetic condition, but you told us that there was no family history and tests were negative for a genetic form of rickets, and this starts to point to an hypothesis of oncogenic osteomalacia, tumor-induced osteomalacia. Just one question: since the patient had no hypercalcemia, why did you decide to measure the PTHrP?
Well, I think that well, you can have hyperparathyroidism without hypercalcemia. Usually it's the secondary, but in rare cases it can happen in primary hyperparathyroidism. But I think this was asked because of thinking about a tumor, and well, she had no elevated excretion of calcium also, but it was requested. I can't tell you now what was the theory for that, because yes, she doesn't have or didn't have hypercalcemia, and she didn't have any finding of hyperparathyroidism. Yeah.
Well, I think
Okay.
that it is interesting here to underline that in the routine, maybe that sometimes we ask for tests that are not immediately necessary, but represent something that happens rarely, and we are not making the most important and thinking about the disease. But I think that we now need to give an answer to one of the attendees who asked why we didn't think about primary hyperparathyroidism since we had mildly elevated PTH. So I think this is an important point to give an answer. And I don't know if you, Carina, or any of the panelists want to make a comment on this. How do you exclude primary hyperparathyroidism in this patient? What are the elements that you watch out?
Well, in truth, serum calcium was completely normal and PTH almost normal. So I think it would be a bit difficult to have a primary hyperparathyroidism with such levels of calcium and IPTH.
Well, I think that serum calcium can be normal in primary hyperparathyroidism, as Carina told, but this most commonly occurs when there is a deficiency of vitamin D, which is not the case in this patient because she had normal 25D levels. So this is against the hypothesis of normocalcemic hyperparathyroidism. And I think that it would be helpful also to have a look at the renal excretion of calcium, even fractional excretion, that in the case of primary hyperparathyroidism is expected to be high.
Yeah, yes, it's expected to be high and it was normal.
Okay, and I don't know, Peter underlines that very low 125D levels with normal 25D points to FGF23 as a potential mediator of the disease. So I think that we are slowly moving towards something.
Completely agree, yeah. Well, before showing you the next step that we performed, I would like also to show you the DEXA test that we talked initially because of the pelvic fracture. So this was performed before the patient was with us, and it revealed severe osteoporosis. And I don't know, what would you think about this?
Okay, I think that Ditte or
well,
Ricardo.
Well, I think she had osteoporosis with a T-score below -2.5. And we also know that she had this low energy fracture, so she had a high risk of bone fracture. So there's something that makes her at risk of having fractures at the moment, but we need to consider how to treat her at present.
I agree with Ditte. To begin with, she had several factors for osteoporosis, so this result is not really very surprising.
We decided to perform a bone biopsy because of the DEXA result, and if you see on your right hand side, this is a toluidine blue staining, and we can see that there are two blue colors, and light here is the bone which is not mineralized, and more blue one is bone with minerals. So here in this magnification, we can't see cells. Here we had trichrome staining, which reveals osteoid, a very high quantity of osteoid, and the mineralized bone in between. And finally, the vancosa, which also gives a very diagnosis imaging of osteomalacia. So this patient has, just looking at the pictures, we don't need to measure anything. We can definitely tell that the patient has osteomalacia.
Okay, Anna, please, no, go back. I would like that you make some comments and make some comparison what you would expected in case of normal bone, because the audience might not be experienced in bone biopsy histology. So what is exceptional, because this is a very clear picture, a complete and full-blown picture of osteomalacia. So what is characteristic of this? I don't know, for example, any comment on the type of bone cells or bone sites that should be watched at in order to have an idea of what's happening? Do you have any bone resorption here?
No.
No?
Maybe here, I don't know if this is an osteoclast, but I don't think so. So I can't see this.
Okay, I think that we should say that normally there is no such redness.
No, yeah. The red and dark imaging is bone. The dark one is the one that have the minerals, and the red one is the demineralized bone. So we usually see these red zones in some spaces when the bone is being formed, and we can see also osteoblasts within this places. Here we do not see cells, but also the magnification is not very high, but we don't see cells, and we see only osteoid without signs of bone being formed recently.
Okay, and can you make some comments on the state of fragmentation of the black trabeculae?
Well, I think this is a technical issue.
Okay.
I don't think it's very relevant.
Okay, and the number of nodes between the trabecula. These are the aspects that those attending should be encouraged to watch at when seeing a bone histology sample.
Yeah, normally there are many arms that goes out out of the image. Probably there should be bone in here that connects to bone here and bone here. So the patient also has a low bone volume.
Well, I think that to make a comment from the chat, I think it is important. We named osteoporosis, obviously, because in front of low BMT values, we can imagine that. But in this case, there is no osteoporosis, and there are no fractures in the trabeculae. That's why I asked you to make some comment on the nodes. This seems a clear picture of pure osteomalacia. Okay, do you agree, Carina?
Yes.
May I add a comment?
Sorry to interrupt. Despite the bone volume parameter, I think it was very low. 8%.
Yes, it was. Yeah.
Yeah,
I can show you.
Okay, and
So
there is also a question, I think, just to try to give answer to those who are anonymous, it's better. Bone biopsy, maybe it was not necessary to diagnose osteomalacia.
Yes, well, it is not necessary to diagnose osteomalacia, and we only perform this to know if the density, if the bone volume, to not assume that all the abnormalities in the densitometry was due to osteomalacia. Although we have first to treat osteomalacia, maybe later on the patient would need some treatment for a low bone volume.
May I comment that the elevated alkaline phosphatase may also point towards it is a mineralization defect or osteomalacia that is present.
Yeah.
Did you measure other bone turnover markers in the patient?
No, we didn't see the bone alkaline phosphatase, and we only see PTH, and we only saw PTH and FGF23.
May I make a comment? Well, I don't think that bone biopsy. I think that bone biopsy. I think it was important because although, as Carina said, not strictly necessary to make a diagnosis of osteomalacia, the truth is that the biopsy showed us a lot of information, and it can contribute to avoiding delays in diagnosis because she has a low bone volume, so this is compatible with the results of the DEXA scan, and we have to understand that we must treat osteomalacia before treating the osteoporosis. So I think that the bone biopsy was very valuable in this case.
I think that here we have the bone volume.
Yes, the bone volume is low. The osteoid thickness is very high, and the bone formation rate or the bone turnover is also low. So we have a clear diagnosis of osteomalacia, and this is the first thing that we will have to treat. So we went to see what was producing the FGF23 and what was the cause for the osteomalacia of the patient, and we asked for a PET test, and we finally found a lesion in the C6 vertebrae, and the patient was submitted to surgery. They removed the cervical cord ependymoma, and now and after 1 month, she started to increase her phosphate level. And the fractional excretion of phosphate also decreased, and she started to walk again. So it was a very good to see the evolution of the patient.
Well, I think that, okay, it is impressive, I think, that it would be also nice to have some details on the times of recovering of the biochemical abnormalities. How long did phosphate need to come toward normal values and other biomarkers, alkaline phosphatase? When can you judge that there is reached a new and almost complete mineralization of all that osteoid volume that was present in bone? Did you check any increase in bone mineral density? That could be very rapid change in BMD.
Yes, that's a very good question. The phosphate level was very rapidly increased. So and the recovery of the patient was also very fast. The alkaline phosphatase still gets longer to decrease, but we indeed are planning to do DEXA to the patient instead another bone biopsy, and I think that we didn't need to perform any medication. Well, between the PET and the surgery, she started to have calcitriol, phosphate supplementation, but after the surgery, we stopped everything, and she was okay. Nevertheless, if we didn't find the tumor, we could go and give the patient borozumab. That is also another way to block the FGF23. And about the treatment of osteoporosis, well, we didn't start that before we are going to do a densitometry, and then we will think about it.
Okay.
Carina, this is a quite uncommon location for this kind of condition. Might this have been the first report in the literature? I ask this because they are most commonly described in the thigh and femur and the craniofacial region. Could this be the first report?
Oh well, I read I think 5 or 6 reports about tumor that were localized with PET, and it was in other. They were in other places, other localizations, but maybe I don't know. I can't remember the exact places where these mesenchymatous tumors were reported.
I asked this because the vertebra are less common locations for this kind of tumor.
Maybe. Nevertheless, the TU is also it can be common, and the tumor is very hard to find in most cases.
Mm-hmm.
Anna, do you have a precise description of the histology of the tumor? Which kind of tissue was it? A kind of bone cells or fibrous cells? Which kind of cancerous cells were found there?
That's a very good question. I saw it, but I don't put it here, so I can't be 100% sure. But I think it was fibroblasts, fibrous tissue.
Fibrous tissue.
Not bone.
So there is a question now. When you cure osteomalacia here, okay, that's fine. But then remains some osteoporosis because this is women in postmenopausal age. So do you also treat osteoporosis here? Do you treat osteoporosis concurrently with osteomalacia or just after curing osteomalacia?
After curing osteomalacia. So I think that before we start treatment for osteoporosis, we should be sure that the patient has normal phosphate, normal alkaline phosphatase at least, and we should be sure that the tumor did not, because sometimes the places are so the places of the tumor are very hard to do the surgery and to take off all the tumor. So the clinical case can recur again. So I think that when we assume that the osteomalacia is completely recovered, we can ask for a densitometry and we can think about it again. I'm a little bit divided if I would do another bone biopsy to the patient. I think it's not necessary, but.
Well, I think that it's interesting also a question, considering that if you decide to start treating osteoporosis and you use bisphosphonate, how can you be sure that there is no more osteomalacia that could be negatively affected by?
Well, to be sure, we had to do a bone biopsy. I think. But the lab results can give us some ideas. Well, the phosphate and the alkaline phosphatase, the bone alkaline phosphatase, should be measured before.
Okay. I think that this patient can be followed with biochemicals in order to have an idea of what's happening. Alkaline phosphatase may take months before reaching normal values in this case. And you also have a look at calcium, PTH, and maybe also FGF23. And,
Yes.
and
Yes.
these are very rare cases. And it may be underlined that not always PET is diagnostic. And there may be different types of PET with different markers that are more specific for the different types of tumors responsible for tumor-induced osteomalacia. I can tell you this because I have a patient in whom we have not been able to find the tumor still. And it's now many years that is receiving burosumab with some efficiency, but.
Yeah, I have also a case where the tumor was not found and the patient is also doing burosumab. So sometimes the tumors are very hard to find, it's true. We tried to do the PET with somatostatin because these tumors have some receptors for that, but not all can be localized.
By the way, Carina, was this a regular PET scan or a DOTA scan?
It's a DOTA.
DOTA scan, okay.
Yeah.
Okay.
I think this will be a difficult case to clarify in a patient with kidney disease. How should we approach these patients? May we miss them if they develop these kind of tumors and have CKD?
Well, I'm not. I'm not expecting a CKD patient to have hypophosphatemia. But you are talking about a patient on dialysis, which that already has hyperphosphatemia. Yeah, if the patient is anuric, it's very difficult and we can miss it, yeah.
I think that the tumor would be diagnosed and recognized very, very late because there is no biochemical abnormality. Maybe that we should only observe very, very high levels of FGF, abnormally high levels of FGF23 that can be responsible for other biochemical abnormalities or clinical picture.
On the other hand, this highlights the importance of bone biopsy in our CKD patients.
Yeah.
Because persistent bone pain and fractures would be probably an indication for a bone biopsy.
Well, but if hypophosphatemia does not develop, do you think that the dialysis patient with this kind of disease would develop osteomalacia?
That's a very good point. That's a very good point.
I'm not sure, because we think that it is hypophosphatemia that is responsible for the deficiency of mineralization. If you do not have hypophosphatemia because there is no renal excretion of phosphate, you will not develop osteomalacia.
Yeah, that's a very good point.
Okay.
Did the patient, just a small curiosity, did the patient regain her autonomy?
Yes, yeah.
Okay.
She was very happy, and she sent a video to his physician, his nephrologist, who is currently following her, with her walking alone in the street. Very good. She was very happy.
Okay, there are other questions. I'm happy that there are so many questions. Could you remind us the array of various tools that can be used to localize the tumor? I think we said something, but do you think that you, based on your experience, there may be other tools if you suspect this kind of disease?
Well, we can do the PET or the MRI to try to localize the tumor.
Total body. And do anti-resorptive cause harm in patients with osteomalacia, or are they just not efficacious?
Sorry, I can't.
Anti-resorptives, if you use the bisphosphonate, for example, in this patient, this is expected to be responsible of some harm in patients with osteomalacia, or are they just not efficacious?
Well, the anti-resorptives block the osteoclast action. So you can block it, but this will not be efficient, yeah. Although I think it can harm the bone also.
Well, I think that the amino-based bisphosphonate are not directly responsible for osteomalacia. They are responsible for a dynamic bone. If you have enough phosphate and calcium, you can mineralize. Maybe slowly, because there is inhibition of, it is mainly inhibition of osteoclast.
But in osteomalacia, you already have low bone turnover. So if you are going to block it more, you will have no bone at all. So I think it will harm the bone also, not related to osteomalacia, but related to the physiology of related to the action mechanism of the drug.
Okay,
There
are a couple of points that I think can deserve some attention. Peter says that FGF23 also directly impair mineralization. This is an opinion, but so do you think that very high FGF23 levels are responsible for some part of osteomalacia that we can observe in our patient, independent of serum phosphate?
There are some studies that relate the levels of FGF23 to increase osteoid thickness in bone biopsies in end-stage kidney disease patients. Yeah. I have a study of so, but the reason why that happens is not known. Yeah. Well, it blocks the activation of vitamin D. It leads to excretion of phosphate. The link to the PDH is not very clear.
Maybe indirectly,
Yes.
But there is one point that is very interesting, raised by Matthias. It suggests that taking selective samples of blood from veins could help to localize tumors. This is a technique that has been employed in the past to localize parathyroid in renal patients. So we could obtain some samples selectively from veins and then have an idea of where there is an excessive production of FGF23. I go and think about this in my patient.
Yes, and in mine also.
Okay, I don't know if any of the panelists want to make some comments on this. I think that we are going to the end part of the meeting. We have 5 minutes left for some additional commentary. So, Ditte or
I have a brief comment
Ricardo.
to Carina. Did you consider the diet afterwards, that the patient has sufficient calcium intake and vitamin D and so on to secure that she still mineralize the bone?
Well, we didn't ask the patient to increase the quantity of milk or other or to vary her diet to increase calcium or vitamin D. And we didn't give her at this point a calcitriol again or calcium. But is a good question, and we have to recheck because the patient has normal calcium and normal vitamin D levels.
Yeah. Well,
and we know that for a patient without kidney disease and with a good kidney function, which is the case, we cannot treat low volume only with vitamin D.
no, but perhaps the calcium intake should be monitored or to make sure that she gets sufficient amount of calcium to
Yes.
mineral. Yeah.
Okay.
I'd like to congratulate Carina for the fantastic images that she brought us. This was certainly one of the worst cases of osteomalacia I've ever seen. It was a very severe picture. Almost all of the bone surface was covered by osteoid. Almost 50% of all matrix was non-mineralized. It was very, very interesting. And I would like to highlight again the great importance of FGF23 in the diagnostic workup of hypophosphatemia. And I'm a true believer of the importance of bone biopsy in these patients, because it wouldn't be very difficult to assume that in the presence of osteoporosis, we will perhaps prescribe and perhaps wrongly an anti-resorptive therapy. So I think that bone biopsy was a very important step here.
Thank you.
Well, I agree, and I would also suggest to Anna Carina to collect the samples of biochemicals after the tumor excision and try to make a comparison with patients receiving or undergoing parathyroidectomy, because these can be completely different situations in which we abruptly reduce the levels of two important players in the field of bone disease. And this could be very interesting to have some suggestions.
Thank you.
Well, I think that these rare cases are very, very important to describe because they help us to understand the pathophysiology of the disease. And we need to take the opportunity to make this kind of reasoning. So, I don't know if there are any other comments. There are no more questions in the chat, and I think that the meeting has been successful because we received a high number of questions and comments. The case is rare but challenging. I think we underlined the importance of performing bone biopsy more widely. Again, it was questioned. It was not necessary maybe to perform biopsy. No, I would say not. It is important to perform this non-invasive procedure, which is much less harmful than kidney biopsy. So while we can earn a lot of information. Well, I look if there are other questions. Last look. Rare case, interesting, thank you. Also, I think we can be satisfied enough. So I think that I can thank all the participants